I'm going to talk about adaptive dosing strategies with a focus on targeted therapies and biologics. That's my disclosures, just in case somebody care. And that's actually the main issue, is why should we bother in trying to seek for alternate dosing in drugs that have been marketed for such a long period of time? And why couldn't you just stick, to approved dosing? Well, you have to keep in mind the fact that actually approved dosing is not necessarily the optimal dosing, especially because, you've got several reasons, but for instance, it's a well-known fact that patients enrolled in phase 2 or phase 3 trials can be quite different than the real-life patients you have to treat, in your respective institutes. And that means that basically the dose that has been finally confirmed and approved has been mostly tested in patients with little comorbidities or reduction in comorbidities, just to smooth the variability. And this very dosing itself comes from dose-finding studies that most of the time have been poorly designed or have been designed using, outdated protocols. And on top of that, we're all talking about precision medicine and 4P medicine and personalized medicine, but we hardly understand how the hell we could do precision medicine with standard dosing. That's as simple as that, actually. So there is a rising number of papers openly criticizing now the way pharmaceutical companies perform clinical trials, and dose selection is clearly fingered as the bottleneck of the pharmaceutical development, explaining the high attrition rates, for instance, we have in oncology, and explaining how so many times we need to reinvent the dosing once the drug has been approved. And just to illustrate my point, I've picked up a single example, Sunitinib, which is a great drug. I mean, that's not the question. Sunitinib has been a groundbreaking innovation to treat patients with renal cell carcinoma. And Sunitinib has been approved with a 50 mg a day dosing on a 4 weeks continuous dosing followed by a 2 weeks break. And if you try to wonder why, what is kind of scheduling and this kind of dosing? Well, if you look at the first papers from the Pfizer group, they show that actually the therapeutic window for Sunitinib, which is actually the combination between Sunitinib and its active metabolite, has been determined as being at a trough level between 50 and 100 nanograms per ml. And actually, that's the therapeutic window in mice, not in human, okay? But still, according to Pfizer, it's pretty much the same. So that's the target. And according to Pfizer, 50 mg a day ensures a high probability to reach the target. And if you try to wonder why it's 50 and not something else, you got to look at the phase 1 trial. And then you got something like that. That's the trial that has been published in 2006, I guess, I can't remember. And that's the dose-finding study. And, first, if you look at the different dosing that has been tested, you got only 4 levels, okay? And they use a 25 mg step. So basically it's 25, 50, 75, 100. And okay, they've done it. And if you try to figure out why they've chosen a 25 mg step, it's just because it's what is written in the paper. They could not do something else. Because at the time, Pfizer was not yet marketing the capsules at 12.5. So they were restrained in their choice by a 25 mg, which is purely linked to some kind of industrial process and not at all PKPD or PK or any kind of science. It's purely something which is industrial. And still, in the 50 mg group, they put 8 patients. And out of these 8 patients, only 5 were in the target. But still, it was considered as being sufficient to identify 50 mg as the RP2D, the recommended phase 2 dose that had been further confirmed in phase 2 and phase 3. And at the end, Sunitinib has arrived on the market with the dosing of 50 mg a day because of 5 patients. And it's not a big surprise that since the very first day the drug has arrived, oncologists very rapidly have tried to do something else with Sunitinib, to keep the drug because the drug was great. But they tried to reinvent a new way to give Sunitinib, and there have been countless alternate dosing, trying to explore different dosing or different scheduling, so you can either keep the dosing and change the scheduling, or you can keep the scheduling and reduce the dosing, or whatever. Most of the time, all these alternate dosing provide equal or better efficacy, better tolerance. So the way we use Sunitinib now in real life is quite different than the way it should be used if you just stick, to the label. So that's the clear demonstration that dosing is an actionable item. We are right in trying to change the dosing for the sake of safety or for the sake of efficacy. So it's not a waste of time, even if the drug has been approved, to try to change the dosing. So beyond Sunitinib, what do we know with targeted therapies? Well, most of the targeted therapies fulfill the prerequisites to perform TDM. So Marcus have just shown something very similar just before, so I'm going to go rapidly on this one. But basically, you got a huge interpatient variability. The PK is not linear. Because it's oral drugs, you got a lack of poor adherence, so it's great, to check sometimes whether or not the patient really takes the pills or the capsules. We have a reasonable good idea of what is the therapeutic window and what are the PKPD relationships. It's quite easy to assay by mass spec assays. It's cheap, it's convenient, it is rapid. And should you be interested into modeling, you have plenty of papers describing the mean PK parameters, so you can do modeling and simulation as well if you want. So, the door is open to perform TDM in routine with most of the oral targeted therapies. And as I can see here, you got plenty of reviews and different papers showing indeed the relationships between exposure, whether it's trough levels or IUC or whatever, or mean CSS, and the clinical outcome, as you can see here. And when I say clinical outcome, I'm talking about both efficacy and toxicity. So basically, the pharmacokinetics drives the pharmacodynamics. And in the pharmacodynamics, you've got the side effects. And that's a very important point because, at least in France, we have a lot of oncologists and we've got a lot of MDs who say, well, listen, why should I bother in doing PK since I've got this relationship between PK, efficacy, and toxicity? So I can skip PK and I just have to monitor toxicity as a surrogate marker for efficacy. And indeed, if you look at the literature, you have level of evidence showing that especially skin toxicity, for instance, with oral targeted therapies, are associated with either response or survival. So it could appear as a very convenient and cheap way to predict efficacy, and in some cases, to change the dosing without PK, but just by using toxicity as a marker. And basically, what the physician have in mind, and what we have all in mind, is this kind of very, over-simplistic representation of the PK-PD relationships, but roughly looks like that. It's some kind of Hill equation showing that if you increase the exposure, you're going to increase the probability of response, and you're going to increase the probability of toxicity. So basically, if you have a patient with little toxicity, and if you have this kind of graph in mind, you may fear that the patient may be underexposed and may have some kind of lack of efficacy. And so it's very tempting to increase the dosing so as to reach higher levels of exposures and so as to trigger toxicities. And once the toxicity has been triggered, then you believe that you're on the right part of the curve and the patient is much more likely to have some kind of clinical benefit. So it's very simplistic. It's the more you put, the more you get. So it's basically the Hill equation. And once again, you got a good level of evidence in the literature, especially in lung cancer, where changing the dosing so as to trigger skin toxicity can help to increase the efficacy. And once again, it's cheap, it's convenient, it's very logical actually, and it's very tempting to do this. But my opinion is that this temptation should be resisted because you have some papers showing that toxicities should be avoided at all costs with oral targeted therapies because they are given in the long run, And there are evidences showing that even mild toxicity, I mean, even grade 1, grade 2 toxicities may deter the patients to stick to the treatment. And you may trigger some kind of loss of adherence. And you got another body of evidence showing that poor adherence has deleterious effects in terms of efficacy. So, okay, it's cheap, okay, it's convenient, but it's a very risky strategy, to try to change the dosing and to monitor the toxicities so as to reach a certain level of toxicity that you associated with a higher probability of response. So I don't think that's the right strategy to seek for alternate dosing using toxicity as a surrogate marker. So instead of using toxicity, especially because we are here in the Netherlands, in the homeland of pharmacokinetics and TDM, well, let's do TDM. And once again, there is a body of evidence which is impressive with oral target therapies. I mean, that's just a table, but which is not exhaustive. But with a lot of drugs, you know what are the metrics. You know whether you should look at the trough levels or the IUC. Most of the time, there are trough levels. You know where are the targets. We know what is the therapeutic window associated with either toxicity or efficacy. And you have even, some consensus about the recommendations in terms of dose individualization. So if you do TDM, you just have to check what are the levels in your patient. And then depending on the level and with respect to the target, you change the dosing. And you don't necessarily need to perform very sophisticated modeling and simulation just to improve the clinical outcome. I mean, you can do it just by reading this kind of table and make some kind of proposals in terms of dosing. Should modeling be your thing? Well, still, you can do it. I mean, yeah, you can use dedicated softwares. So I'm not going too deep into this part, but basically it's all related to performing Bayesian identification of individual PK parameters of the patients. So provided that you have mean PK parameters, and most of them are already published, so they're quite easy to implement in any kind of software. Well, if you have a new patient in your institute, you make a sparse sampler. So sometimes, most of the time, a single sample is enough. And you make a Bayesian estimation. And then you can calculate what are the individual parameters of your patient. And once the individual parameters of your patient have been identified, you're the king of the world. You can do whatever you want, and you can make simulations, and you can test different dosing and different scheduling, and at the end, you're able to make a finely tuned recommendation in terms of dosing. And that's personalized medicine. Even if you don't want to bother, with a sophisticated PKPD model, just using a PK model with no PD helps a lot. And actually, it can help you to solve very practical and very logistical issues. For instance, as I told you before, most of the time, the therapeutic window is calibrated on the trough levels. So basically, the sample you need to have is a trough level sample. It's a residual concentration. So the sample has to be done just before the patient takes the next capsule or the next pill. So, well, say that seems easy, but in real life, sometimes it's complicated. Basically, if the patient takes the pill at noon, he has to have an appointment in the hospital between 11 and noon to be sampled. And next, he's going to take the pill. But sometimes, the patient was expected at 11, and it's 3 o'clock, it's still not there, because something went wrong. Something went wrong in the unit, something went wrong in the lab, or something went wrong with the patient, and he just phoned, I'm sorry, I live away from Marseille, I missed my train, and I cannot make it this morning, I will be this afternoon. So you don't have the truth level. And if you don't have a model, you cannot make the interpretation, because most of the time you need to have the truth level. But if you have a PK model, you don't care anymore, because if you have the PK model, you can have your PK model that's going to make the simulation and gives you a virtual trough level. And you can make your interpretation, and you can make a conclusion, and you can make a dose recommendation based upon something that has been simulated, not something you have been actually measured in the patient. So that gives you a lot of flexibility. if you do just TDM, sometimes you cannot make a recommendation because it's not the right sampling time. And it's very frustrating for everybody, for the physician, for the biologist, and for everybody. But if you have the PK model, now it's what we say to our oncologists in my institute. We say, we don't care. You can sample a patient whenever you want and whenever you can. I just have to have the right timing. I want to know exactly when was the last intake as compared with the sampling time. And this is it. And next, the model does the job. So it's very, very flexible. And just to show you an example, that's a case of a patient in my institute. He was treated with Sunitinib. He was a young patient for a metastatic renal cell carcinoma. And actually, his MD was worried because the patient had no toxicity, which is very classical, because most of the oncologists, they like to have toxicities because, once again, they think that is going to be associated with a better efficacy. And then the oncologist called me and said, well, listen, I've got an issue with this patient because, first, he has no tox. He was treated at a standard dosing, 50 mg a day. He has no toxicity at all, which is worrisome. And more worrisome, when he's in the off period, it starts to be painful. So I fear, it may be not as effective as I wish. So maybe the patient is underexposed. So I say, okay, listen, let's make some TDM. And we made a first sample. And we managed to have the trough level. And indeed, the patient was underexposed. It was below the therapeutic window usually expected with Sunitinib. It was not in the 50 to 100 nanograms per ml range. So I told the MD, okay, listen, yeah, you are right. There is something wrong, and it's clearly associated with the clinics. The patient is underexposed, so I think we could, shift up and increase the dosing. So we made the first step, and we shift from 50 to 62 mg a day. And the clinics were getting better. There was still no toxicity, but at least the patient was not painful anymore when he was during the 2 weeks break. And we made another sampling just to check, whether or not we did correct and we did improve the exposure level. And we missed the trough level. I had a peak level, actually, but it's not a big problem because I got the model. So, okay, rather than, based upon the assay I made at 2 hours, I was able to make a simulation at 24 hours and to get a virtual trough level. And the patient indeed was in the therapeutic window. But he was at the bottom of the therapeutic window. And because there was still no toxicity, we discussed again with the physician, and we said, well, listen, he's a young patient. I know you want to have a complete response. So I think you still can speed up, and you can still shift up, and increase again the dosing. So we shift to 75 mg, and we made another check, on TDM, just to check whether or not, the patient was still in the therapeutic window or whether or not it was too high. And the clinics was getting still better. Surprisingly, there is still no toxicity, but there is still no painful events during the off period. And above all, upon RECIST criteria, the patient was in complete response. And the TDM has confirmed that we missed again the trough level, but I made a simulation that the patient was at the upper range of the therapeutic window. So based upon the TDM plus the clinics, we have decided to stop and to say, well, listen, we're going to stick to the 75 mg a day dosing, which is 50% higher than initial dosing. And the patient is still doing all right. So as you can see, TDM is a very convenient tool to help guiding the physician in his decision to change the dosing or not, because it provides the physician with some kind of safety in his decision because we show him where is the patient in terms of exposure levels. So that shows you how TDM can be useful, and that was at the time where I just could make some kind of PK simulation, but now we have a PKPD model with Sunitinib, and I'm sorry, this is a French screenshot, but retrospectively, I've tried to use this model in this very patient just to find out, what the model would have recommended as a dosing, and here are the data. the model says exactly the same thing, but in a single shot. So basically, if you use a more sophisticated model, you can save time, and you can reach the right dosing level in a single shot, rather than making step-by-step empirical increase in dosing. So that's very, very powerful as a tool, because you save time in renal carcinoma. Saving time is a great thing to do. So now, for instance, we do TDM in routine in my institute, for example, for a number of oral targeted therapies, and just to talk again with Sunitinib, that the list of the 30 last patients we made, and look at that, 80% of the patients required a change in dosing as compared with approved dosing. So basically, the approved dosing is less and less the standard in my institute. And because of TDM and because of PKPD model, we are able to change the dosing. And when I say change the dosing, sometimes it's minus 75% or an increase in 100%. I mean, the model says double the dosing, and you can do it safely, and it works. So once again, there is plenty of room for improvement just by changing the dosing. So, so as a conclusion for targeted therapies, well, yes, we can do TDM, we have good level of evidences, we have the tools, they are easy to assay, and it works. And that's it. So to finish my talk, I'm going to make a short conclusion on the biologics, where basically the level of evidence is not as clear-cut as it can be with oral targeted therapies. Okay, the PK is non-linear. You've got a huge interpatient variability plus intra-patient variability. But to be frank, we don't know exactly how narrow is the therapeutic window. We don't know exactly, we talked about that before, so I'm going to speed up. But we don't know exactly what are the PK-PD relationships. And frankly, it's tricky to measure monoclonal antibodies in blood. So you can do by ELISA if you have a very specialized lab. We have developed mass spec methods, which is a very convenient alternative to ELISA in my lab. But still, it's more tricky to assay a big molecule than to assay imatinib or dasatinib or whatever. So still, what do we know about biologics? Well, first, inter-patient variability in PK is not a joke. It's just massive. And it's funny because, we were discussing before about the differences in terms of clinical outcome depending on the dosing. To me, that's rubbish. The dosing doesn't mean anything with biologics because you've got such a huge overlapping between patients that you cannot guess, and you have no clue about what is the actual exposure level of a patient when you give bevacizumab or trastuzumab or ipilimumab. Unless you make the measurement, you don't know where is your patient. I mean, look at the point there. It's amazing. That's the first fact in favor of developing TDM. The second fact is that while we have less papers describing clear PK-PD relationships with biologics, but there is a rising number of papers showing, that's an example with trastuzumab here, that even if with a fully bio-guided molecule like trastuzumab, which is only given in HER2 positive patients, you've got huge differences in terms of survival depending on the trough levels. So that strongly suggests that exposure does matter with biologics. And that's trastuzumab, and there is another nice study by a French group on bevacizumab, where there is no biomarker, but pharmacokinetics apparently. And just showing you something we've made in my institute with cetuximab in head and neck cancer patients, for instance. And we made TDM, and we just look at the Cmin and the Cmax, and once again, look at the variability between the patients. It's amazing. And you got an overlapping between Cmin and Cmax depending on the patients. That means that in some patients, residual concentrations in cetuximab were higher than the maximum concentration in other patients. And conversely, in some patients, at the end, residual concentration were zero. There is no cetuximab. And it's not a question of poor adherence. I mean, it's infused. So the variability is massive. And once again, well, we have evidence, some kind of relationship between trough levels and clinical benefits. So that suggests, once again, that, well, maybe TDM will be helpful and adaptive dosing strategies will be helpful. We have fewer data with immune checkpoint inhibitors. So Dr. Beans showed something with nivolumab before, and we have some decent data with ipilimumab. And once again, there is no differences in terms of survival if you look at the dosing. There is no difference. But if you look at the trough levels, there is a difference. So once again, that will suggest that exposure does matter. But to be totally frank with you, and it has been discussed before, there is an issue with the PKPD relationships with biologics, including with immune checkpoint inhibitors. It's all related to TMDD and to the fact that tumor burden and antigenic mass may increase the clearance of the biologics. So basically, if you have a big tumor, you're going to increase the clearance and to have less circulating drugs in blood and vice versa. And actually, you know, when I made my presentation, I'm trying to convince you how important are the exposure, because that could support the need to perform TDM. But frankly, you got a lot of people who say that actually I'm making a mistake and I'm making a confusion between the cause and the consequence. I'm not sure, to be frank, that the PK is the cause of the clinical outcome with biologics. It may be just the consequence because of the TMDD. I don't know if you see what I mean, but we talked about that before. So that's the biggest issue I have. And as long as we will not be able to set up clinical trials, you know, where we increase the dosing in patients who are underexposed, we cannot have the answer about that, you know. And it's just like, you know, if you look at this picture, some of you will see a very young and very attractive woman, and some of you will see a very old and very ugly woman. But it's the same picture. It just depends on the perspective, you know, and your state of mind. I don't know which of the one you see. I can see both, actually. It depends. But it's the same issue we have, you know, with the PKPD of biologics. We don't know exactly who does what. And from now, well, the level of evidence is getting better, but it's still not as good as we could. Still, even if we think that, okay, let's forget it, we cannot increase efficacy by performing TDM of biologics, including immune checkpoint inhibitors. TDM could be still useful just to save money, because most of the immune checkpoint inhibitors are shifting for standard dosing to a flat dosing, and it's based upon the assumption that all the cancer patients weight 100 kilos, and it's a well-known fact that when you got a cancer, you're healthy and you're big. And this huge increase in dosing makes that most of the time flat dosing is associated with circulating levels much higher than what is requested for a total target engagement. So basically, it looks like a waste of drug and a waste of money to shift from standard dosing to flat dosing. And maybe that TDM, you know, could help us, well, maybe to cut the dosing, or maybe, you know, to postpone the following courses, because there is no need maybe to administrate so regularly very costly drugs at such a high level of dosing. If the target is already inhibited, for instance. So that could be another application of TDM with biologics. So I'm done. Thanks for your attention. That's my take-home message. Frankly, if you don't measure the drug, you have no clue about what's going on in the patient in terms of exposure level. And it's quite easy to perform TDM. So just try it. Thank you.